People really should be proud of many of the elements of their health service. What I want to make sure is that people are proud of their health service all of the time.
A Welsh Kiwi, Dr. Andy Phillips came to Cork and Kerry to be the Regional Executive Officer South West. He has worked in clinical, operational and strategic executive leadership roles in healthcare in the UK NHS, Australia and New Zealand for the past 37 years. He maintains his clinical qualification as a consultant clinical scientist. Since 2009, Andy has been leading large-scale health system transformation with a passion for delivering value for money through integrating health and social care. He has practiced co-creating health and relationship-centred healthcare for over 20 years, with recent work on leading kindness and compassion in healthcare. My name is Juanita Gaidra, a Programme Manager with National Quality and Patient Safety, and it's a pleasure to welcome Dr. Andy Phillips as our guest on the 26th episode of Walk and Talk Improvement. So Andy, we've just heard an overview of your career to date, one underpinned by your commitment to quality and patient safety. Can I ask, what was the starting point for you on your quality journey? What was that hook, that moment you decided quality was going to be important to you?
Yeah, well, thank you, Juanita, and thank you so much for giving me the opportunity to have this conversation with you today. Well, really, I feel very old when you talk about all the years that I've spent and all the places I've worked in. It's over 40 years now since I started being involved in some aspects of health. And I really got involved with quality and safety after a family friend died, unfortunately, of a bowel obstruction because they couldn't get the appropriate scan or service at the weekends, as it so happened.
Oh, I'm sorry to hear that.
Yeah, it was a big event in my life, and it gave me a passion for improving quality and safety. And as I got involved more in providing and delivering and transforming health services, I found out more about our record across the world in health services of about 1 in 10 people who comes into the health service being harmed as a result of that interaction, and about half of those being avoidable. So despite all the work we've done on quality and patient safety over all these years, we still have a very significant number of people harmed by the interaction with the health system. The fact that maybe those figures haven't shifted, that 1 in 10 figure hasn't shifted over time, really reflects the complexity of healthcare now, and also how we are able to do so much and to continuously improve the quality and improve outcomes for people. But we still have those gaps in the Swiss cheese that Liam Donaldson pointed out so many years ago.
Yeah, I'll never forget, nearly 25 years ago, when I first applied to what was the Southeastern Health Board at the time, and my mum gave me a copy of the service plan. And it has a picture of a pram on it. It was an orange cover with blue writing. But I can remember her telling me at the time, she said, we look after people from cradle to grave. And it was the cradle to grave. It was that whole expanse of life. Within your region at the moment, your key goal within the HSE Southwest is to make communities proud of our health service. That really resonates. Can I ask, where did that goal come from?
So, in fact, my responsibility as REO extends prior to the cradle because we have a population health accountability. And what we know is that if you look after young families and women in pregnancy and the very young children, then their outcomes are going to be so much better over the course of their life. So yes, we're a health service that needs to look at population health outcomes because 80% of our health and well-being is from those social determinants of health and health behaviours and 20% from the services that we deliver. It's really important. But as you say, once we have a human being to look after, that we provide them with excellent care throughout their life stage.
That's quite challenging when you think of the population health and you think of the expanse of that. On the surface, it seems like a simple goal that our communities will be proud of the health services that we have. But how do you make that a reality? How do you translate that into something that's real?
Yeah, first of all, I think it's important that we all have a common purpose. And we've seen the benefits of that in events like COVID, where everybody had a common purpose and maybe we got things to move forward a little more quickly than we would otherwise. So my first reflection is having a common purpose is important. And then I think of the success of institutions like GAA in Ireland and the pride that local communities have in their local GAA team, whether it's winning or not. And that sense of community involvement and participation and ownership is really important. So my other reflection would be that in other countries, their people are much prouder of their health service than maybe I've seen in Ireland, where the health service does face pretty much constant criticism. The health service in Ireland does such great things every day. So I think it's really important to have a common purpose, and people really should be proud of many of the elements of their health service. What I want to make sure is that people are proud of their health service all of the time. And I find it very difficult that we have people waiting on trolleys and we have people waiting for appointments, and particularly we're not able to provide those high quality services for children with disability and through CAMS.
Mm.
And so I want to change that. And I think there's a really good objective that people will be proud of those services. And yes, we'll still get it wrong, but I think generally if the staff are proud of the services they provide and the people are proud to receive the services, then we will have transformed those health services much for the better.
And I think as well, something that strikes me is how much the dynamic of healthcare has changed in the past 20 years, and more so the responsibility and ownership from a patient perspective or a service user perspective. Do you think that's important at the moment?
I think it's always important that people have significant ownership of their own health and well-being. And just in terms of acting on that real interest that people will be proud of the health service, we now have 8 commitments to the staff and to the patients. We have 4 commitments for patients, 4 commitments for staff, and those are based on the HC values of care, compassion, trust, and learning. So for patients, we are committed to valuing the time of those people that we are privileged to serve. So really important that we take every opportunity that we don't make people wait, particularly for older people, people who are in the last 1,000 days of life, maybe. And we sort of ask ourselves, well, how many of those days would those people want to stay in hospital if they didn't need to? So valuing time is important. Under the compassion value for patients, we want to put ourselves in the shoes of those that we are privileged to serve, really understand what it's like to be a patient. Under trust, we say that we involve those we're privileged to serve as equal partners. There is a power dynamic in the health system, and we need to overturn that so people do feel they have that power and agency in the health service. In terms of learning, we've said that we'll avoid harm to patients and staff, and we'll continually work hard to improve our services 7 days a week. Because we know about the health service in Ireland that when you can get into it, when you can access it, it's pretty good most of the time, but there are still those holes in the service, and particularly when senior decision makers aren't available. So we're working really hard to provide those services 7 days a week. But it's also, of course, about colleagues. So under those same HC values for colleagues, we want people to authentically live those values every day and to hold ourselves accountable for that. Under compassion, we want to support each other to be the best that we can be, to train ourselves well, to develop ourselves well. And then under trust, we're saying we're one system, one team, one budget. So we don't have the wrong door for people and telling people, I'm sorry, we can't help you. One door, one system, one team, one budget. And then my reflection is we do need to improve our governance. So under the learning value, we're saying that we govern our services with transparency, accountability, participation, integrity, and capability. So we're able to demonstrate good governance all the time.
Definitely, there's a lot in that. You've said before, there's no safety without cultural safety. It's something that I've heard you speaking about. When you think about those things that you're talking about, what are the areas where you think we really need to focus on to create a positive quality and patient safety service?
Yeah, absolutely. So there are 4 things that I'm trying to do all the time with quality and patient safety. And the first thing is to learn from when things unfortunately have gone wrong. And even when there have been near misses, those near misses are often a much better way to learn. And then the second thing, of course, is to learn when things have gone right. There's an awful lot of learning in when things go right in the health system. We need to use that learning to apply to other areas where maybe it hasn't gone right. That appreciative inquiry, build on our strengths and apply those to other areas. The third thing that I'm doing continuously is to understand where things are likely to go wrong. So that prediction of when things are likely to go wrong and stop that happening. And then the fourth thing is to continuously design services where we've designed the harm out of those. And we have a number of things that we're doing to achieve those. So improvement cycles, obviously very important for when things go wrong, and increasingly use people with lived experience to understand how things have particularly gone wrong. I was involved, for example, in some very traumatic work in Victoria, where I worked previous to here, where a number of parents had lost their children through harm that occurred in the health service, many of those through sepsis. And so we asked the parents to help us to design the services that would prevent other children coming to harm or dying. So that was really important. And then increasingly using people with lived experience to do those investigations of the health services supported by professionals. So that involvement of people with lived experience is important. But you really prompted me to talk about safety culture. So just in terms of that immediate, that first horizon, that thing that we're doing immediately, it is really developing a patient safety culture so that everybody feels safe to be able to raise concerns. The airline industry has that very well.
Yes.
An airline pilot can work with a new crew and a new aircraft and do that very safely, one that he or she has never flown before, because they have standardized processes, and any one of that crew can say, stop, we need to look again at some of the aspects of the flight. So that patient safety culture, and my reflection across many health systems, is we do not have an appropriate patient safety culture where maybe junior staff or parents or patients feel able to speak up and prevent bad things happening. And that's my job, to put in a safety culture. And part of the way I do that is through establishing good clinical governance. And that work on clinical governance has been a strong feature of wherever I've gone. The patient safety culture, of course, is really a social movement for change. And we do face changing situations in the health system. So a safety movement and developing that leadership at all levels, not just in the high levels of organization, is critical. And then the third horizon, which we're always working on, is having those system integrators in place. So we're using healthcare systems engineering in particular to have an integration of all those things that lead to high quality services.
Okay. Often, when people think of healthcare systems engineering, they think of the technical, task focused, process oriented. How do you keep the person at the center of that? You talk a lot about the importance of staff experience. You talk a lot about that lived experience of patients. How do we make sure that's central to any redesign or systems design that we're doing?
Yeah, absolutely. Well, the way that I've chosen to frame it, and framing is really important in building social movements, is around kindness and having a health system that's systemically kind. So we hear about systemic racism and other things in other systems, and that just means it's a system property. And what we've chosen to do is to say our health system should be systematically kind and have that as a property. I'm very much aware of the kindness of the people that I work with and the communities that we work with. Immensely kind, more so probably than anywhere I've ever lived or worked. I've experienced personal kindness from people, but I'm not sure that our system is always kind to the people who work in it or the people who use it. So that's my job, to build kindness in as a system property. And where there's a single patient waiting on a trolley to be admitted to a hospital, or a single person waiting a long time for their outpatient appointment, then I don't believe that I'm running a system which is systemically kind. And I'm very much aware of the surveys that the Nurses Organisation and the Forsa Organisation have published over the last few days, really showing that people who are working in the health system are not always experiencing a good quality of their working life. And I need to change that. There's a really big difference between being nice and being kind as a property of the system. So when I go to a hospital emergency department, I see people on trolleys and I see the staff providing cups of tea and food and those sorts of things. I see people who are being nice, but I'm seeing a system that isn't kind, because if it was, then those people wouldn't be on trolleys. And so one of the things that I'm very keen to do is to say, well, look, the service that you walk past is the service you accept. So I can't really walk past a person on a trolley in an emergency department without wanting immediately to do something about that, but also over time to fix that system through healthcare systems engineering. So that's not a feature of the system.
I'm struck by that comment about your immediate desire to fix it for that person on the trolley. And I think in healthcare, we have that urgency of need, that immediate desire to step in and fix a problem. But very often, when you unpick it, the question is, are we fixing the right problems? So how do we balance the urgency of the problems before us while allowing that time to maybe interrogate and respond to the real problem?
Yeah, I think it's all about organizational culture and doing two things. The first is to be absolutely committed to making sure the system works effectively for the people that we serve. And that can take a little time to put in place. But I'll come back to the fact that I can't walk past an episode of poor care. So if I see somebody in a corridor or on a trolley or otherwise having a poor episode of care, I really want to have a conversation with the colleagues who are working in that place to see what is there we can immediately do to provide better care for that person. And I certainly never interfere in the safety of the care provision. So I wouldn't move somebody into a resuscitation space, for example. But I certainly would have a look to see if we had any side rooms that weren't being used, or try and make sure that we create a space on a ward immediately for that particular person. And I think seeing myself as a senior leader in the organisation, caring not just about the system design, but that immediate care for that person, that has a positive impact on the culture of the organisation.
Okay. I'm curious about that sense of agency. So obviously you're a senior leader. For a lot of staff working in the system, they don't necessarily see themselves with that lens. And you've been working with 300 leaders across the system seeking to develop that culture of continuous improvement. And one of the things you introduced was a permissions card. Can you tell me more about that? And was it a conscious use of the word permission?
Yeah, it absolutely was. Well, the first thing I did when I arrived was I took out the top 30 odd leaders in the organization, the senior leadership team, and I established with those senior leaders the commitments that I've spoken about. And that was a start to building the culture of the organization. And we'd established some of those behaviors we wanted to see in ourselves and others. We established that we'd hold ourselves accountable for delivering those things. And then what we thought was, well, this needs to spread. We need to establish this movement. So each of those 30 odd leaders were asked to nominate 10 people who they felt were leaders in the system, not necessarily people who held high level leadership positions, but people who they knew to be influential. So we've got some very important leaders in our organization who just really go above and beyond and are really role models to people, porters and nurses and many others. So we invited 300 people to participate in the next series of developing the culture of our organization. And we worked with them on some tools about giving feedback and about how to do improvement work. And they all got involved in a piece of improvement work. But one of the things I learned from my work in integrated care elsewhere and learning from places like Christchurch in New Zealand was that if people come back into the workplace after having had that experience of working with me and others, then they come back into an organization culture which isn't the same as that we're trying to develop.
Yeah.
In all of our regions, we're moving from having a large number of different organizations, bringing those together, and each of those organizations had their particular cultures. And so we wanted to create together a culture, the way we do things around here in Cork and Kerry, and we needed that to be action focused. So we did work on the acute care system and trying to make that effective and building on the culture through that. But that permission granting really says, as REO, I'm giving you permission to improve the health service. I know you've interviewed Don Berwick for this, and one of the things that Don Berwick would say, you have two jobs, the job you're doing and improving the job that you're doing.
Yes.
So essentially, all my colleagues now have my permission to improve the job that they're doing and really to challenge people who might not want them to do that. The word permission was really interesting because other colleagues felt it had connotations, particularly from me as a male senior leader working with a workforce which is 85% female. How dare I suggest that I need to give people permission? So we did have that conversation. But that word permission is so much more powerful than support. I give you permission, I give you agency to change those things that you feel that need to be changed. So that permission granting was really important. I could have used other words like support, but I wanted to use a word that was really strong and that showed that those colleagues had my authority to change the things that they felt needed to be changed, even if there were other people in the organization who maybe didn't want those changes to happen. As long as those changes are consistent with our commitments, then they absolutely have my backing.
And can I ask, you talked about governance earlier on and the importance of governance.
Yes.
What sort of governance marries with that giving of permission? What do you need to put in place to ensure that decisions or actions are being taken within the governance structures? Or do we need to change the governance structures to allow for this to happen?
Yeah, well, we absolutely do need to change them. We are changing because, of course, we've set up different structures now. So we do need governance appropriate to those structures. And that's one of the really urgent pieces of work with the regions. But there are really 5 elements that I've set out where we need to improve clinical governance. So leadership and culture, developing an improved understanding of governance and assurance, developing governance capability, in particular, establishing role clarity. One of the pieces of feedback I've had is people are really unsure of their roles or their accountabilities. So we're going to be putting in place some governance training, and I've appointed somebody to lead on that. And that in particular means having that strong patient safety culture at all levels.
Yes.
The next thing would be that partnership with people with lived experience and having an understanding in the organization of what a golden asset that feedback is. So not treating a complaint as a nuisance or a bother, but treating it as a really golden gift that people are giving us to help us to improve. But I talked about using people with lived experience in those leadership positions as well. And then the next thing would be risk management. Probably our risk management needs to be improved, better understanding of risk appetite, providing feedback, making it a learning health system. The next thing I should probably talk about is workforce and having a workforce which is capable and appropriately resourced. Many of my colleagues in my area say they're rather stretched, and I need to change that and make sure we have the correct workforce. One of the things we'll do with that is improve the number of people who are actually well to be at work. And at the moment, I have about 7% of my workforce, or 1,400 people, who unfortunately are not well at any one time. So there's a huge amount of workforce training happening. Management, I think, in particular, there's a lot of focus in all the literature about developing leaders. Of course, we need to do that. But actually, management capability, particularly operational management capability, is something for my area that I need to develop. I have many people who have the title of manager, but I have very few people who have had management training, particularly to allow them to manage in an integrated health system. And then the last thing would be clinical practice and appropriate guidance and process, particularly as we start to standardize things, taking on that example of the airline pilot who can come in and fly any aircraft with any crew. Having standardized processes is really quite important.
Yes.
We need to learn a lot more from things like mortality reviews. I don't have a well-developed system mortality reviews here, but those need to take place in a psychologically safe environment with learning built in.
Okay. There's a huge amount in what you just touched on there. And I might just come back to one or two of those pieces. You talk about the data available. We think about measuring quality improvement. How do we know all of this is going to be a success, or how do we know that it's working?
Yeah, absolutely. And of course, we do have an awful lot of metrics that we collect, and very few of those that we actually use. And this is something I've been working on throughout my career. So one of the things that I've developed is a safety and quality minimum dataset. So based on those Institute of Medicine 6 domains of quality, safety, timeliness, effectiveness, patient-centeredness, productivity. So having some metrics under each of those. So I have 6 metrics under those particular headings, and those are the things I want us to measure. So it'll be 36 metrics, a mixture of things that you can measure some months after something's happened, things that you can measure at the time, and then those proactive measures, and measures that are quantitative and measures that are qualitative, a mixture of outcome and process measures. So having those in place, that'll give me a good handle on the safety of the system.
Okay. And you talked earlier on about being able to predict things that are going to go wrong, or looking to see how we can learn from, so we minimize the risk of repeating things.
Yeah.
Do you see that coming from that same data set?
Yeah. So these safety and quality minimum data are a mixture of predictive and long lag and short lag predictors. The best predictors actually are using a mixture of the patient feedback that we get.
Okay.
So there are online patient feedback systems in place across the world. Using that combined with other forms of data about patient feedback, you can absolutely predict with a pretty high degree of sensitivity where problems are going to occur. And this is not even using the power of AI. So if I just talk about AI in the safety and quality area now, so already in Ireland, there are systems that can predict the people who are going to come into our emergency departments with a very high degree of accuracy. And then we have AI that can support physicians. We have virtual physicians who can be on the case 24/7, who then link in with the people and the various teams that we have to provide services to people to prevent them having an exacerbation or having an acute episode which would lead to poor quality and safety. And then we have pathways that we've agreed, modernized care pathways, which can be made available. We can provide clinicians with more time to do their work by using AI tools that will not just do a digital transcription, but provide a care plan. And then we already have set up, because I learned about this in Australia, we already have an urgent virtual care system where somebody can get an opinion from an emergency department physician or a pediatrician or a geriatrician, and I think in the future a mental health clinician, as we build into a full virtual emergency department, which has been evaluated so well across the world. So not only can we predict when things are likely to go wrong, we can predict when people are likely to become ill and put really appropriate services in place to prevent that from happening.
And tell me, what sort of skills do we need to be thinking about from a staffing perspective? We think of AI and you think of things like ethics, critical thinking. In the broader context, you think of things like environmental impact and so on. But what sort of skills do we need as a workforce to start using AI effectively?
Yeah, to be honest, my experience just recently has been that general practitioners giving exposure to an AI tool pick it up really instantly. I think it's more people having the interest just to pick something up and try it. These tools are often so intuitive, it doesn't take any training and you can use them pretty much immediately. I think that sense of curiosity really that I would pick up rather than a skill, it's more of an attitude of curiosity. And how can I best serve the people who come to me for help? What sort of outcomes am I trying to achieve? So I think it's less those hard skills and more that real interest in patient outcomes and service and connecting people up. The most important leadership skill really is connecting people up. So connecting things up, as I've just described, connecting various things up, connecting people together and connecting ideas. The most important management skill, I think, is that healthcare systems engineering, where you, with others, you co-design a service, you test it out, you continuously refine it, and you continuously evaluate it to see if it's still fit for purpose. And I'm not seeing too many of our services that have been proactively designed. One of the things that I disagree with John Berwick and IHI is when they say the systems are perfectly designed to achieve the results that they get, because I have very seldom seen a well-designed system, let alone a perfectly designed system. Health services tend to come together not by accident, but by a series of steps that aren't really designed in a process that we would see. So that engineering approach, I think, is very powerful, being very intentional about the design parameters, things we're trying to achieve, and then testing and continuously improving.
Yeah. And in that space of co-creation, it's complex in some ways. On a fundamental level, it's very simple, but when you begin to unpick it, it's new for a lot of staff. They haven't worked in that space of co-creation or co-design before. They mightn't have had the permission to do it, or they mightn't have felt. And I think that's the other differentiation in my mind, I think, when it comes to permission, is sometimes we feel we don't have permission. So one of the key questions that we hear is that if patient partners are taking on a leadership role, what's the role of staff in that? Where does the governance and accountability sit? How do we have conversations about the boundaries of our role? In your experience, and you have a doctorate in this area, so you're well placed to be able to speak to this one, I think.
Yeah, so I've been practicing this for many years, and I got my doctorate about 15 years ago now. And what really struck me in doing the academic work for the doctorate was what I learned that I didn't know. And in particular, what I didn't realize was the importance of the power dynamic. And it may sound obvious now, but the great difference in power between the people we serve and ourselves as staff, and some of that is knowledge, and we protect that knowledge by using Latin phrases, for example, don't we?
Yes.
Or making our language inaccessible, or even making our clothing inaccessible by wearing uniforms or having those badges of office. And so people interact with us as symbols. So it's really addressing that power dynamic that actually some people are very comfortable with. I have a very good colleague when I worked clinically who I trained, and that colleague came to the end of their training and said, "Really sorry, Andy, I've got to leave your department to go to a different department because I didn't spend all these years training in order to have patients involved as equal partners." And it's really difficult for some colleagues that there's that power sharing. We're seeking specifically to change that power dynamic. And of course, there's power dynamics between different types of colleagues, isn't there? So one of the things I'm really concerned about at the moment is doctors in training and the different power dynamic that exists between themselves and their consultant colleagues, and the difficulty we have in raising concern about patient safety issues in the moment or even after they've occurred, because that power dynamic and that anxiety that exists that their careers might be affected or they will suffer a penalty in some way. And that's even more acute, particularly for somebody who's an inpatient, to raise concerns about their care when they think having raised a concern might result in them not getting such a good service. We really need to be very aware of that and to address it.
And have you come across practical ways to address that or to support it? Because it's an old problem. It's one of those things that we see time and time again. And no matter how much training we do, you touched on it earlier on, bringing the leaders out of the system to give them training, and then they go back into the system that isn't quite where it needs to be because it's evolving and it's changing. How do we manage that?
I think there's a number of ways. If I think about the particular issue where a parent or a patient or a child might be concerned that they were becoming acutely unwell, and this has been the case in a few situations recently, hasn't it, in Ireland, and as I said, in Victoria where I worked. But one of the things we did in Victoria was this virtual emergency department I spoke of was also our mechanism for people being able to get a second opinion from a relevant consultant clinician. And that consultant clinician could make an intervention with a treating team on their behalf. Having that mechanism where people felt able to get a second opinion was very important. And that comes under Martha's Law in the UK and many others across the world. So I think having a system designed to do that is really quite important. But other parts of it is training. So I don't believe that many people in the health service really realize exactly how much power that they have and how powerless other people have. When we were doing the work in Victoria, we had a number of parents of children who were consultant clinicians in the health system, and they were unable, because they didn't believe they had the power, to raise a concern about their child with the treating consultant team. Or when they did, they felt that they were ignored. And unfortunately, the consequence of those children, a number of them, was that they died because their parents, who were consultants themselves, felt unable, that they didn't have the power to raise that. So I think an understanding, and I'm sort of struck by the work that's been done by Harvard and others on unconscious bias.
Yes.
So if you've ever done the Harvard unconscious bias test, you realize that we all have these biases, and it's not a terrible thing we have these biases, but we need to be aware of them and make sure we do things about it. So I'm very aware whenever I go into any situation with a colleague about the organizational power I have as the REO and the potential impact that people may think that I can have on their lives. So I'm very aware of that power dynamic. And I hope that with the language that I use, maybe even the clothing that I wear, some of the other things that I do, that I become much more approachable, and I try and minimize that difference in power.
Yeah. And I don't think it can ever be fully negated. I know in our conversation with Tom Burke, we touched on this as well. And I think the sense from my own experiences is that at the end of the day, we still hold the budget. The HSE generally still calls the meeting and so on. So there is always that power dynamic there, whether you want it or not. And no matter what you do to negate it, it's still present. One of the things that has also come up for us in the past is very often we become very reliant on patient partners at a time when they have a lot of their own grieving, their own challenges, and they can sometimes feel it's very hard to step back then from the health services. How do we support people to become involved while also allowing for the fact that actually in some instances, if they feel they don't have that energy or the passion, that they don't have to get into that space? How can we still continue to make our service while being aware of that?
I think, again, it needs to be a system property. So I think it needs to be the forefront of our minds whenever we do anything in our working lives. And I was just reflecting on my year and that I haven't done enough to work with people with lived experience. And in fact, just after this, I'm going into a meeting with some service providers to talk about an experience I had recently working with parents of children with disability. And I would say, of all the services that I have in Cork and Kerry, it's our service for children with disability that gives me the greatest cause for concern. I know we have very dedicated, committed staff and organisations that are working tremendously hard, but the outcomes for children with disability are poor. And I was just struck when I went to that meeting that there were 20 sets of parents there of children with disability who'd really not had a good service. And I was humbled by the fact that they thanked me for coming. Well, look, I'm the REO. I get paid quite a lot of money to have this meeting. You've given up time from work and other commitments to come and see me.
Yeah.
And then again, the further thing I felt was humbling was that these parents were almost apologetic that they were raising these terrible issues about their children with me. I want to change that dynamic by us being much more sensitive to that lived experience, understanding that it really is a gift. And involving people in the governance of our organisation, not just getting their opinion, but involving them in the organisation and giving them some of that power that we have. So part of it is making what we do accessible. So using the right language, not using language that's designed to exclude, but also by having lay people as chairing groups. I'm very keen to recruit somebody to chair our Quality and Patient Safety Committee rather than having a professional do it. And making sure that people feel they have agency, and in the way that we conduct meetings, making sure that everybody can give their contribution, and maybe those with lived experience give the first contribution rather than the last contribution. I've learned how valuable that contribution is to me. I have to say, I did a lot of this work in the NHS in Wales, but I had a blind spot. In every group that I'd worked with, I had as equal partners people with lived experience, except for a group when I was redesigning the service of people with dementia. And it was my bias that I didn't think people with dementia could contribute effectively to the meeting. And I was so wrong. Immediately, I invited people with dementia into the meeting. We were able to change the service beyond recognition for the better.
Wow. Okay. There's a lot in that, and it brings to my mind that idea and the challenge of getting to those hard to reach groups. So we don't necessarily have everybody coming to the room. And have you experience of reaching out to people within communities that don't necessarily see the poster to invite them to come to the meeting?
But I think that's the point, isn't it? So I'm very conscious of my own privileges, the fact that my economic privileges, my education, the position I have in the health service, all great privileges. And I'm very aware that in the past, health services have been designed by people like me for people like me. If you look at services for women, for example, many of the drugs that are tested are not tested on women. And so we have an inherent bias towards the pain medication, for example, not really tested on women.
Mm.
But when it comes to other groups, so I worked with people in difficult socioeconomic circumstances in South Wales. But the starkest difficulty in serving people I found was with the Maori in New Zealand, with the Aboriginal people in Australia, and now the travelling community in Ireland, all of whom have at least a 10-year difference in life expectancy. And my experience was, look, you can't engage with people who are Maori or Aboriginal community or travelling community in the same way as you would engage elsewhere, because we have a Western medical sort of philosophy engagement. And in particular, these groups want different things than we think that they should have. So rather than us saying, well, we think the best thing for you would be to have everybody in your community have their blood pressure measured and to have blood pressure medication, instead going and talking to them about the things that they valued. I had a really good example looking at Maori women who are pregnant who smoked cigarettes. Very high proportion of Maori women smoke cigarettes, and understanding their lives, that smoking cigarettes was one of the only areas of agency that they had in their lives. So understanding people's perspective and not trying to put our own perspectives and then just offer them services we think they should have is really quite important.
Yeah.
I learned that very early on working with women with breast cancer, and options to either have a mastectomy or to have radiation therapy. And the prevailing view from treating clinicians was that women would preserve the breast at any cost. But actually, that wasn't the case. If you do simple things like providing option grids where you set out the risks and benefits of all the approaches, then people will choose very different to what we as clinicians might choose for them.
Our perceptions can be very different than reality sometimes in terms of people's needs or desires. One of the things I did want to touch on was there's a lot of change obviously happening within the system at the moment, and I'm curious about what advice you'd give leaders of teams on how to engage with staff or with patient partners or service users on the quality and patient safety agenda. What practical advice would you give them?
Well, I think the first thing is listening with curiosity, because it can be quite emotive to talk about these things. And rather than reacting negatively to what people have to say, I think it's listening with curiosity and fascination and compassion and understanding that the outcomes that people are seeking may be very different to those that you feel that they should seek. I think there's that understanding. One of the videos that we use is called It's Not About the Nail. And if people haven't seen that, I really suggest you look at it. And it's really a video of somebody having a conversation about an issue, and one of the people having the conversations coming to a solution that says you need to take the nail out. And that's not what the person wants. It seems like an obvious solution to us, but it's not about the nail. It's very good. It is about listening to people, understanding their perspective, and understanding there may be many different perspectives on an issue.
Okay, thank you for that. And the other thing that I'm coming back to is that idea, as you said, about people coming back into the system with new ideas, or our junior doctors coming into a system, and you want to create that sense of just culture and an opportunity for people to share things. What advice would you give leaders to support the workforce as it becomes more engaged and more vocal and wants to share those things for those leaders that may not necessarily be in that same space?
Mindfulness is a really helpful quality to build on. And when you practice mindfulness, you really understand that people coming into the workforce now are very different to yourself. So I happen to be a boomer, and I have a certain set of characteristics as a boomer, which are very different from the millennials and the generation X's and Y's and Z's and all the people who are coming in who are also digital natives. And so some of the things that we've accepted for many years, like poor access to digital information, they're just not acceptable to the people coming into the workforce, because they, apart from themselves, they just can't understand it. It's difficult for me to understand, but I have to say that I'm maybe one of the people who's accepted that we don't have access to digital information over a long career. So I think that would be different attitudes, expectations of work as well. I suppose I'm so old that when I went back to when I first started in healthcare, there was an expectation you might have one career and a job for life, even in the same hospital or the same healthcare system. And people have a very different expectation now that maybe they'll work at something they enjoy for a while as long as it meets their needs and the psychological contract that they have, and then they'll maybe go and do something else. So we really need to understand the attitudes and perceptions and and the drivers of people coming into the workforce now and adapt what we're asking people to do to meet their expectations.
So that curious listening again.
Yeah, and then acting on it. It's one thing to listen, but you also have to act and redesign things that meets people's needs.
That aren't working. I wanted to ask you, we've covered a lot of topics and I'm struck by your hope and your commitment to the future. But do you have a personal mantra or a resource or a book that you go that anchors you in your work?
I think there are many. When I was dealing with personal difficulties and professional difficulties, the Stoic philosophy was very helpful to me. So the works of Marcus Aurelius in particular is a sort of personal tool. I think that mindfulness training, mindfulness work is very important. But I think it's really being open to new forms of knowledge and using AI actually to help with understanding those new forms of knowledge. The particular work that I value is the work on relationships and trust. So all that work that Stephen Covey did on building self-trust and trust of other people and organizational, societal trust, that thinking about trust and behaviors and relationships is really important. What was really critical for me in my development was the time I spent in New Zealand with the Maori people and understanding the centrality of relationships. And no matter what we're doing, we can never lose the trust. We always need to seek to build on the trust and maintain a strong relationship. And if you have trust and strong relationships, then you really can pretty much resolve any problems that you have.
So true. It's the foundation of everything. If you were starting on your quality and patient safety journey again, what wisdom or insights would you like to share with those listening?
I think in particular is looking for some system properties. There are a number of system properties I hold dear, and one of those would be value-based healthcare. So that would be minimizing the use of low-value healthcare. So understanding what value, strong value, low value that there is, and looking at best value. And looking at how to work with really good practice, with really strong practice, and get that embedded quickly, and not assuming that good practice will just immediately be delivered. And then just constantly trying to work on removing waste from the system, unwarranted harm, unwarranted variation, accepting that some variation is very helpful, but there's a lot of variation that's not helpful, and trying continuously to take that out of the system. So in terms of best value care, I think we want less in the way of patient safety, incidents, and we want more of those things that I spoke about high quality. And there are some particular principles I think are important. The first principle I would say is we're trying to achieve health and well-being with patients and professionals as equal partners through co-production, co-creation. So trying to get rid of those power dynamics that are problematical. The second would be providing care for those people who have the greatest possibility of benefiting first. So really thinking about the traveller population and people living rurally and women and those people who have the best opportunity to benefit from our healthcare input and concentrating on delivering that rather than thinking necessarily about people like me who are already really advantaged in the healthcare system. I think the third principle would be do only what is needed, no more, no less, do no harm. I think that's really critical, and being very aware of when we are doing harm and designing those systems to take that out. And then that variation in healthcare is really stark. The variation in practice, the variation in outcomes that we accept.
That's really helpful. I think in particular, when you started talking about the values, the first thing for me is who sets what's valuable, who determines that. You've touched on co-creation and the importance of that. It's so positive and refreshing to hear that. Andy, thank you so much for your time and for joining us on Walk and Talk Improvement. As we come to the end of the podcast today, we'd like to thank you for sharing your wisdom and your experience so willingly. It's been such a privilege to speak to you. And for you, our listeners, we hope that Andy's insights will continue to inspire you in your work to improve health and social care services. We hope you enjoyed this episode, and if you would like to hear more content like this, you can listen to Walk and Talk Improvement wherever you get your podcasts. Thank you for listening.